Dr. Naganath, maybe you can start the discussion. We have another 20 minutes. Yes.
I tried here. We not the ICG, but fluorescent yellow dye we used. And then I found that if you are doing stoma, then there is no difference between whether you are trusting your visual impression or do a dye. If you are doing a stoma by default, what Dr. Sastry says. And second, when we are doing a colonic pull-up, or where I do get a chance not to do a staple but cut the bowel, you just cut the bowel at the end, like the colon pull-up before doing anastomosis, incise it by using a scissors, a knife, see good flow of blood. That's enough knowing the vascularity of the conduit. And now, of course, we are doing a study that in comparing the fluorescent dye with pricking near the staple line where we're going to do anastomosis. We do prick with 22 size needle and see the color or the flow of the blood. If it is there, what is the result? It's too early to say the results to you.
Yeah, Dr. Naganath.
Thank you, sir. So at the outset, I would like to thank you for inviting me to this forum. And all the presentations yesterday and today were comprehensive and resourceful. And I also learned a lot of points. Actually, to begin, regarding today's regarding Dr. Vaibhav's this thing, he has covered everything well. I would like to add one thing. There is something called tube ileostomy with biodegradable material. That's also useful to avoid, ileostomy. And then, as Dr. Robert said, if you can use Colo Shield or some interluminal stents, and then we can avoid stoma. But all those things are not 100% foolproof. And he also mentioned the ghost ileostomy. I don't know how many people have done that ghost ileostomy. And we all know that stoma is a disability. Apart from causing physical morbidity, it causes more of psychological morbidity to the patient, impacting the quality of life. So that's why everyone wants to avoid the stoma. But if you want to avoid a stoma, then one has to be very careful to pick up the leaks at the earliest and tackle it. And I feel after LAR for cancer, we should always do a covering stoma, because the problem is the vascularity of the distal stump. Proximal stump we can always verify. Distal we are going to staple, number one. And number two, in teaching centers, multiple team operates. One team will dissect, one team will do anastomosis. And another thing at the end, it is the gut feeling of the surgeon. Even though the donuts are intact, the leak test is negative, still it can leak. So at the end of the thing, it is the surgeon's gut feeling also plays a role. If he's not happy, if he feels something not correct, then it's always better to go in for a trauma. And
yeah, please, you carry on.
Regarding Dr. Diksha's this thing regarding the single stage, 2 stage, and 3 stage, my this thing is, everyone said for FAP one can do a single stage, but how do you know that there is no malignancy in FAP? Supposing if the biopsy comes as malignancy, then what will be the treatment? Whether we should do a 1 stage or should we do a 2 stage procedure, a 3 stage procedure? So I want to have the opinion of other faculties. And regarding this diversion following the pouch, everyone talks about stoma, ileostomy, but what ileostomy is ideal? A simple loop ileostomy, divided loop ileostomy, or a Turnbull's ileostomy. Because sometimes if there is any distal problem, the pouch-related problem, you may have to leave the stoma for a long time. In that case, a simple ileostomy may not function. Maybe after 6 weeks, it will lose its this thing and it will not function. So these are the areas I just wanted to touch on and invite the comments from the other faculties and also students.
Yeah, Dr. Das, Dr. Sastry.
Dr. Naganath, Babu, I do not understand how a missed malignancy in FAP and ileostomy or no ileostomy, how they are connected. A single stage or a two stage, it doesn't really matter there when you have an unrecognized malignancy in the edge of an FAP. I don't think that is a factor at all. If you have a standard protocol of doing a two-stage procedure for all IP, the pouch anal anastomosis, then it is fine. Otherwise, you have certain indications. Say for an FAP, obviously you would be looking for a polyp at the edge and a suspicion of a malignancy that you would be counter-checking before you embark upon any surgery. So that may not be really a factor there.
Supposing there comes as malignancy, you may have to give adjuvants, no, sir? Then in that case?
No, that's exactly what I'm saying. Say if you have a pouch already made, there is no other way. You cannot escape from it.
Okay. But if we anticipate such things, then there is a role for doing a diversion. Okay. Then next is which stoma is better?
Can I comment on FAP? I think in a FAP, a good colonoscopist normally, can make it out which area is looking suspicious. If it is a small multiple, then it's okay. But if any of the area looks slightly suspicious, then it's a different ball of game. It's different ball.
Then regarding the stoma, which is preferable, a simple loop stoma or a Turnbull's?
Okay, I'll address that. I think there's no study to say which one you should do. What is written in the textbooks is when we do a loop stoma, it has two parts. One is a afferent part. One is little bit protruded. One is little bit shallow. So invariably, what happens with the effluents come from one side and small amount they start going into the other side. And if you see the pouch patients or the where you have already done a stoma or the low anterior resection patients, after about 15 days or so, they will say, even some people after a week, they will say that I'm passing some amount of stool down below. So they are not completely diversions when we are doing it. So my suggestion is, if you're really thinking that the anastomosis is really risky and patients is not very fully optimized, then better to go for a uncut route. I have done in 2 patients, and day before yesterday I restored one of them. So uncut means you make a hole in the mesentery and using a TA stapler, thoracic anastomosis stapler, just staple it. So theoretically that should work well. What is written in operative surgery is to avoid that shallow versus the effluent going into, to avoid effluent going into the efferent limb, ultimately downwards. What you can do is you can do a omega loop. So if you do a omega loop, the chance of going into the distal limb is theoretically not there. But constructing a omega loop has its own problems, post-operative complications like rotations, adhesions, and ischemia. So I think if you're not very happy with your anastomosis, better to be on safer side, and the patient has multiple medical risk factors. That is also very important if you're going for a re-exploration very quickly or second time, then better to go for a uncut loop stop.
Next thing is, we are talking so much about whether to do a stoma or not. Do you have any scoring system? So most of the thing what we do is only subjective feeling. And the objective, do you have any objective scoring? In the literature, it's not available, and even if it's available, it's not validated. So what is your take on these things?
See, if I am to answer that one, there is no objective scoring, and it is practically not possible because there are so many factors, and objectively to measure those factors, like for example, if you're doing a low anterior resection or ultra low anterior resection, how to objectively say that that is good or not? It's beyond your visibility. One Japanese study says that you do a scopy and see for mucosal ischemia, or if it is blue, then they delay the oral feed, or they go for the ileostomy, which they have extrapolated from the cervical esophagogastric anastomosis. They routinely do that. They do a scopy on the table on X-ray and take measures like that. So if we have to score this, we have to take maybe about some 30-40 points and then calculate and validate. Yes, there is a theoretically you can go for it, but as of now it is not there.
Can
Yes.
I,
Can be a research thing.
yeah, can I just comment on that? Previously I was giving ileostomy only on ultra low, but what I am doing now is I'm giving a ileostomy on anyone if I am cutting the pelvic peritoneum and going between the vas and the rectum. So this is what I have. It's a very simple, if you cut the pelvic peritoneum and if you are separating the vas, no, separating the seminal vesicle from the rectum, I will give a ileostomy. Dr. Nandi gives ileostomy in almost all the patients of rectal. But what I do is if I go below the pelvic peritoneum and if I am going between the vas and the rectum and going lower down, previously I used to only do in ultra low, but now, and it's working well. It's all depends on what you practice. And if it is anything, if I have a anastomosis above the pelvic peritoneal line, I don't give any anastomosis.
So one thing is, if the mesocolon is very bulky, for example, and you're going for a staple anastomosis, would that be a factor for you to consider for stoma?
See, as you always said, that there are so many factors. If you have intraoperative event, if you got a bulky mesocolon, or if you got a very very large mesorectum, and if you have fired 3 stapler, uh, also if it is a narrow male pelvis where you are not having a good visualization, and if you are there is a donut and donut is complete but you are not happy with the thickness of the donut, so there are so many factors. I think with time, with the experience, what where you will give a stoma or where you won't give a stoma.
So one way to go about it is what we are thinking at one point of time, that we know what are the risk factors for increased anastomotic leak. There could be some major factors, some minor factors, and then you give some point to the major factors and some point to the minor factor and see how it is going about. But it is so extensive and each one has so many variables to document. At least 25% of them is very difficult.
So it's better to have lowest threshold to do a stoma if needed. Now, next thing is I would like to know from you regarding the anastomosis, how to check. Usually we check by air leak test. Now, is it useful to use a colonoscope to inspect the anastomosis and see the mucosa also? Is it really going to be useful or not?
I would say a lot of surgeon they put a colonoscope in UK. A lot of surgeon put a colonoscope in. I used to do it in some of the patients. And putting a colonoscope, if you put it gently and not pushing too much of air, because you don't need to go all the way. You just need to go to the anastomosis and that's it. So it is not detrimental putting a colonoscope in. Another thing I will share with my experiences, like in UK, 1/3 of my patient will be obese. In obese patient, although we say the risk of anastomotic leak is higher, but I will, if possible, if I am happy with the surgery in a obese patient, I will be very reluctant to give a covering ileostomy, because giving a covering ileostomy in a obese patient, they are, because majority, or I would say majority of mine is laparoscopic. I would like patient to be up and about in on day one or maximum day two. And what I have found out in obese, once they are up and about, obviously there will be a risk of anastomotic leak in 5%, but their quality of life is much better if you don't give a stoma, because there is a problem with their tummy bulging, and there is a lot of problem with maintaining a stoma. So this is a paradox where, although the obese, we say there is a high risk of anastomotic leak, but I usually avoid giving a covering ileostomy in obese patient. In those patients, what I do is I put a Foley's catheter just above my anastomosis and flush it 3 times a day or 4 times a day.
Then
Will you retain the Foley's catheter, or you'll introduce then and there?
So I will introduce at the time of surgery. But when you are, because anastomotic line, so I'll put a Foley's and fix it there. And yeah, I don't routinely use Foley's, but in few selected cases, I do.
If somebody injects the balloon at the level of anastomosis, then that can cause damage. So what about the Baker's anastomosis? How many people prefer Baker's over end-to-end anastomosis? Does it impact any this thing leak?
So we have 2 more minutes. So any concluding remarks from Dr. Sastry and Dr. Das?
Not a concluding remark, but Western countries, they do scopy almost for all anastomosis except small bowel to see that, but that is counted as a procedure, and the cost is also put on that. But we have now enough evidence to say that if you do a anastomotic testing by using either air or air, there are studies comparing air versus water versus betadine, which they say yes. So if you can establish that there is no leak by inflation study, then the result of the anastomosis is very good, and that has been shown by studies. The scope actually in rectal anastomosis hasn't changed the management as like esophagogastric anastomosis.
Can I just comment? In a Western countries, they are doing a colonoscopy on a left-sided anastomosis. They are not using it for right hemicolectomy. No, they are not. It's only for the anterior section or sigmoid colectomy they will use, not for right hemi or extended.
No.
Yeah, because you said all the colonic.
No. I meant all except the small bowel, and the right hemicolectomy includes small bowel.
No, you didn't. I thought you mean all the colonic.
No.
You said on the left side.
Dr. Shastri, any?
Yeah, I think we had a wonderful discussion of leaks in coloanal and colorectal anastomosis. By and large, we have agreed with the standard principles which are agreed upon, although there is a mention of avoiding a stoma and what are the circumstances where you consider avoiding a stoma in a low anterior section. Particularly, as Dr. Rawat said, obese patient. Fortunately, we don't get that kind of patients here, where an ileostomy is likely to, you know, may not be really flush or like a nipple, and then if it retracts, it'll be quite a bad thing. You know, the morbidity of an ileostomy which is sunken is bad. So we must have an open mind there. But by and large, we have agreed that any anastomosis which is below the peritoneal reflection, which is low anterior section, uh, as a routine, we would consider a stroma. The IPA, again, a two-stage is a standard procedure. A single stage is generally not preferred, but then in a FAP, we may consider in an ideal circumstance where you have a very good anastomosis, and you might consider doing a single stage. And anastomotic leak, all the various grades of leak. It's important to grade the leak and then have an expectant management and identify the gross intraperitoneal leaks and don't lose time in re-exploration, either laparoscopic or open. These are the issues which we have discussed, and I think by and large we have agreed upon.
I think there is a mistake.
Say, if you, yes, please.
There is a comment very,
Dr.
very
Sitaram wants to underline the statement made by Vaibhav that we should be very, very cautious in following the Western guidelines when dealing with Indian patients, because there are so many factors which may be different. So I think that's
I think it's absolutely crucial. That's what I'm saying. I won't do single stage in Indian patient. I won't do single stage ileal pouch anal anastomosis. I won't. And I think Dr. Sitaram has said it absolutely right. And this is what you should do. And as Professor Nandi always say, think global, act local. This is what should be done. We should not be going and reading the American and European paper and start practicing. You need to think Indian.
Thank you, everyone. We half a minute, because we have a tradition.
Actually, I wanted to conclude with this. There are usually 3 questions asked to me in my round by the students. So to complete this, if you can answer these 3 questions. One is they always ask after low anterior resection, if you're not done a stoma, when to start orally. Second, they ask whether to do a contrast study routinely in this patient before starting orally. Third, if there is a radiological leak but no clinical leak, then what to do?
Quick answers. Who will take that?
I think the first question is I will start feeding pretty soon. I don't like to keep NG too much. If it is say 100, 150 or less than 100, I'll take the NG tube out. I take the drain out also early. And because if there is a leak, you would know. And if it is a radiological leak, then you become cautious. Then if it is a radiological leak, then obviously you would like to keep the drain in, because what I feel with the advent of intervention radiology, even if there is a leak later, uh, it doesn't make much of a difference whether your drain is there or not. Some of the time, patient has got a leak and drain is not draining that leak. So one was feeding, sir. Second was radiological leak. If it is a radiological leak, then obviously, you will see.
Should we do contrast study in all cases?
I don't do.
I don't do.
So just
Thank you, sir.
I do it if I've done a esophageal surgery or total gastrectomy. That is the only place where I do the leak test. where I do the contrast study, I don't do it in anterior resection, but I've got a low threshold. If patient is in ILS for 3 days, or if patient is not progressing well, I won't wait too long. I will do the study sooner.
Diksha, half a minute, but that I'll say that if there is a doubt, instead of a contrast study, do a proper CT, because more important is to see whether anything is collecting inside. Diksha, just half a minute. We need to close.
Last one comment. If we are not doing a routine contrast study, sir, then I don't think there is a question about a radiological leak.
Because, sir, if you are doing a CT scan to look for radiologically, that means the patient is sick or patient is not doing well. So means something is wrong. Thank you.
So with that, I would like to thank all the speakers and Dr. Sastry and Dr. Das for agreeing to moderate this session. And I'll keep everybody informed about what is the progress as far as how many students and surgeons have watched the uploaded videos. And thanks to team of Dr. Avinash Tank in Dwarika Hospital in Ahmedabad. Thank you all very much. Thank you, Dr. Naganath, Dr. Rawat, for joining us. Thank you.
Thank you, sir.
Thank you, sir. Good night.
Good night. Good night, everyone. Thank you very much.